Okay, we're going to go on with our talks because I don't think any discussion on quality for an organization like ours, which is highly affiliated with a hospital system like Beaumont Hospital, would be complete without having Dr. Flanders here. Dr. Flanders serves as the Executive Vice President of Quality, Safety, and Clinical Effectiveness for Beaumont Health System. He's responsible for overseeing the quality and safety functions for the entire Beaumont network and for oversees the Beaumont Clinical Integration Councils. He came in 2008, and I have the utmost respect for Dr. Flanders, have had the opportunity to work with him on a number of projects, and he knows an awful lot about quality and cares an awful lot about patients. And some of you guys will be happy to know he's a pediatrician. He actually, and this is where I didn't realize that he went to U of M as well. So he attended there for undergraduate degree and then went to the University of Illinois College of Medicine for his MD degree, and then pediatrics at Methodist Hospital. So he went to work for Clarion Health Partners and was involved in the Senior Vice President for Medical Quality at Clarion Health Partners, which ultimately became Indiana University Health. So, Dr. Flanders.
Thank you.
Thanks, Steve.
Good evening, everybody. I really appreciate a chance to be here tonight to talk a little bit about the hospital perspective on quality. I'm not going to go into this much because Dr. Spollinger was kind enough to show this in his slides, other than just to point out that at the base of this, the Institute of Medicine aims is safety, and that's the one I voted for as a hospital guy, just because that's the thing that we struggle with the most. You know, as you all know, hospitals do a lot of very high-tech type stuff right now, and that's always a very, very significant concern of ours. The other things are important too, but that one is really at the foundation. Sometimes people ask me, what's the difference between quality and safety? And this is one definition that I like. You know, quality basically being free of deficiencies, but safety meaning freedom from accidental injury. So both of these things are important. Another way I like to think about it is, if you think of it, if you were building a building, you want to have a good, strong foundation on the building, right? No matter how good a job you do on the upper floors, if the foundation is not solid, you're going to have a problem with that building later. And so I guess the airline analogy would be, you know, safety is getting there alive. Quality is, was the food good and did they not lose your luggage? That sort of thing. Everything's important, but getting there alive is extremely important. And on that topic, I just have one iClicker question for you today, but I'd like you to answer this 1 through 5. According to the Institute of Medicine, how many patients die in U.S. hospitals every year due to preventable medical errors? Wow, we're getting a lot more responses to this one, Steve. Okay. They like that question? Okay, let's see how you all answered. So let's see, the most common answer was number 4. That is the correct answer, by the way, according to Crossing the Quality Chasm from the Institute of Medicine. Congratulations, you pick up your prize at the end. A few people guesstimated a little bit more, but take that number, take the lowest number, 44,000, divide it by 365, and it's a pretty shocking number. And this is based on some pretty solid evidence. So that's why in the hospital area, everything's important, but safety is really number 1. So how do errors happen in high-risk environments? And a lot of the stuff I'll show you tonight really comes from outside of healthcare, from nuclear power and other industries, the airline industries that have really come a long way in terms of safety. But some of you may have seen the Swiss cheese before, but things are trying to happen wrong all the time, no matter where we are, whether it's our offices, the hospital, and that sort of thing. But most of the time, If you think of the Swiss cheese layers, the holes are not going to line up, and somebody's going to catch that error. An alert pharmacist might catch it, a nurse might catch it, someone will catch it before it reaches the patient. Every once in a while, though, when all the slices line up and the holes are in perfect alignment, that allows a latent error to get through and actually cause harm to a patient. And so our job to prevent the errors is really to try to close as many holes in the Swiss cheese as possible. You know, replace it with American cheese if that's feasible, but to make it so that the holes don't line up. I'd be the first to admit the results of your autopsy were very surprising. So, so how do we learn from errors? Errors happen. They happen in every hospital in the country. Sometimes we have errors called sentinel events. These are the really serious ones where harm occurs or where there's a significant risk of harm. But for every one of every sentinel event that occurs, there are hundreds and hundreds of little things, little small things that don't cause any harm at all, but it was lucky that they didn't, or if they were combined with a few other things could have caused harm. And so we see this as a great learning opportunity because when you analyze the near misses, you have the opportunity to catch things before they become the actual errors. And for those of you that practice at a Beaumont hospital, we have a system on the web page, if you just click on quality on the website, where you can fill out a simple form and report something that happened or even almost happened. And every morning at all three hospitals, we have a meeting for about 15, 20 minutes with a bunch of folks that get together on the phone and review the reports from the day before, look and see what do we need to get after right away, and what holes do we need to start closing in the Swiss cheese before they become actual errors. This is a great learning opportunity. We get, just at the Royal Oak Hospital, 30 or 40 of these every single day, many of them from nurses, some from physicians and other caregivers. The other thing that we've learned is that when you're trying to close the holes in the Swiss cheese and improve safety and quality, you want to aim high in a chart like this. And so, for example, there are really effective ways to prevent bad things from happening. Like if you try to leave your keys in the car or leave your lights on in a modern automobile, it warns you, right? It's not impossible, but it makes it pretty hard to do it. Versus if we were to look at a serious safety event and the only thing we came out at the end would be a suggestion to be more careful or a new policy that we would write about, please remember to always be careful when administering medications and always give it to the right patient at the right dose. We know those things are completely ineffective, and so we're never satisfied with that. We always try to aim higher. So for example, one of the things that a lot of hospitals, including ours, have done recently is installed bedside barcoding systems. So now when a nurse is going to give a medication to a patient, the patient wears a wristband. They barcode the wristband. It brings up their list of medications, and then they actually barcode scan the medication, and if it doesn't match, it warns them right there. And this system catches hundreds of potential errors every single month. It's an absolutely amazing technology. So those are the kind of things that gets up into the forcing functions and fail-safes category, and our goal is to try to aim high as much as we can when trying to figure out fixes for these things. Here's an example. These are all 3 bottles of heparin, okay? The 2 bottles on the left were involved in the death of 3 infants in a hospital in Indianapolis, Indiana. Happened to be my hospital a few years ago. And what happened was you had this bottle. Normally, this was in the neonatal intensive care unit where the small babies are cared for. Normally, you would have this kind of heparin in the medication machine, but by accident, this kind of heparin, which is 10,000 units, and this is 10 units, was in the drawer. It was kind of dimly lit. 3 different nurses gave it to 3 different babies because they were so used to it, of having this kind of heparin in there, but they just didn't notice that the label was just slightly darker at that time. Okay, the same error happened to Dennis Quaid's twins at Cedars-Sinai a couple years later, and the company hadn't done anything about it to that point in time. Well, after that, they did produce, this is what 10,000 unit heparin looks like now. So if this were accidentally in the drawer where this were, you're going to notice it, right? Versus you can see how easy it would be to confuse these two. So that's what we mean by strong fixes for errors. That's really what we need to move towards to help ensure patient safety. So I'm going to switch topic a little bit at the risk of getting shot, up here on the podium. I'm going to mention the dirty word evidence-based medicine, but I look at this as not cookbook medicine at all. I think we're all aware of it. There really is precious little evidence for a lot of what we do. But there is evidence for some things. Some of the things like for, if you have someone having an ST segment elevation MI, getting them to the cath lab and opening up the artery quickly has been proven to be helpful. There are certain drugs for heart failure that help. We know that there's antibiotics that work well for infection if they're given to prevent infection at the correct time, and et cetera. So in the hospital setting, we look at evidence-based medicine. Are for those things for which evidence exists, can we deliver it very, very reliably? And now the expectation for this from the payers and from Medicare and Medicaid is 100% for most of these things. And one of the things that the electronic health record is really helpful for is it helps you to hardwire this. So you can put the order sets right online. You can issue alerts and reminders and if you forget something or you're about to do something wrong. So it's very helpful because it's hard to remember all this stuff, and the rules do change from time to time. But you know what the average time, though, in medicine from the time that something is proven to be very, very helpful in the peer-reviewed literature to when it actually is in general practice almost 100% of the time? Anybody have a guess? Pardon me? 17 years, absolutely right, Dr. Spallinger. It is. Isn't that amazing? It takes 17 years. I think the classic example was beta blockers for either heart failure or heart attack. I can't remember which one, but the definitive evidence was published. 17 years later, we were all doing it. So again, it takes us a while to get there. Safety culture is another really important concept when it comes to creating a safe environment, and this is something that we borrow from aviation and nuclear power. The components you'll see listed there, very important, is a non-punitive culture. It doesn't mean that it's blame-free. There are certainly instances when people are accountable for the actions that they make, but for example, the nurses that made those errors with the heparin were not punished because that was clearly a system issue. 3 different people, all experienced people, made the same error, and that was something that we needed to fix in the system. Another really important part of a safety culture is that everybody has to feel comfortable speaking up, and as physicians, we have a role in this because sometimes we create an environment that's known as the authority gradient, where if we're rounding in the hospital, the nurses may feel uncomfortable, and so anything that we can do to try to prevent that and try to make them comfortable speaking up, even if they're about to see us do something wrong, we want that to happen to try to prevent errors. So that's just a quick thing. There's a lot more to this. We measure this on every nursing unit in the Beaumont hospitals and work to improve the units that need to be improved. Here's some examples of some of the ways that we're graded in the hospital industry. There's a website here you can go on. This is Medicare's site. Called Hospital Compare, and for example, the evidence-based measures that I mentioned before for some of these things are all published out there. You can look up any U.S. hospital and see the scores. We're in a pay-for-performance program, both with Blue Cross and with Medicare, and we're graded on these, and as I mentioned, the national average for most of these is around 97 or 98%. The performance payments begin at the national average, and they top out at 100%. So the difference between 98, 99, and 100% can be $500,000, for example, for a set of measures. So it's amazing, just one little percent, one patient can make a big difference. We have a collection of all of our quality and safety measures at Beaumont. We call the Quality Matrix, and it's big. It's 1,100 things. Not all of these are part of pay-for-performance, thank God, at least not yet. But we have about $50 million at risk right now for performance on all of these. And then there's this question of efficiency and the value equation, if you've heard of that. Value, as most of you probably know, is quality divided by cost. So the way to maximize value is improving quality and lowering costs. And frequently, you can do both at the same time. That was proven many years ago by Deming and others, that doing something better and more effectively lowers the cost. And so you raise value quickest by doing that. So what are some of the things that have been tried in healthcare, to try to address this? Well, we're all familiar with this one, right? It's a little lonely there on HMO Appreciation Day. We tried that one, and there's benefits to all the things that I'm going to show you here. Some benefits. The generic is cheaper, yes, but for real savings, go for the placebo. So we're still working on generic use, right? Even though sometimes generic drugs aren't available for every condition, that sort of thing. Your company's new health plan will cover your heart surgery, but changes in your copay mean we take your liver. for many times the employers and the insurance company, this is really one of the only levers they can pull, right? They control the payments, and so cost shifting to patients and increasing their out-of-pocket costs is one of the few things that they have direct control over, and so we've seen that happen. I can't afford health insurance, but I found a vet that saved me 70% on my vasectomy, so I haven't seen a payer go quite this far yet, but. And the Heimlich maneuver is complimentary, CPR is $5. So, that's the carve out, right? So a lot of things have been tried. Nothing has really, as David said before, really proven to bend the cost curve yet or to be the panacea for increasing quality. But some interesting things have come out just recently, and this was one of them. This comes actually from the American Board of Internal Medicine that partnered with a bunch of different specialty societies to come out with a program called Choosing Wisely. And I have the website for you right there. And what they're trying to do here is to try to empower physicians and their patients to say, for some of these things that are sort of preference-sensitive things, which things are really supported by evidence, what should really be done, and when should you question whether you even want to have it done or whether you want to order it or not. So these were the criteria that they set forth, and it was amazing. They had 9 specialty societies that they worked with originally, and more are coming on board now. And you can go on the website and see all the detail behind this, and there are different things that they came up with. And then, you all know Consumer Reports, right? That's the one that rates the cars with circles and things like that. So Consumer Reports took this information and came up with summaries of a list that are designed for patients. So for example, they have a handout for when do you need antibiotics for sinusitis, or what about bone density tests and that sort of thing. So some of the commonly done things that maybe we do a little bit too much of, that Consumer Reports has put into friendly language and taken the evidence that the ABIM came up with and come up with these. And so I'd encourage you to take a look at these online. Some of these are actually pretty good. And then there's another group called the American Association of Medical Colleges, or AAMC, and they took this concept and ported it over to the hospital environment. And so they looked at these 6 categories and said, what are some things that maybe we're doing a little too much of in the hospital that we might be able to cut back on. And so some examples of this, they found that often albuterol was overused. Patients on breathing treatments, maybe 3, 4, 5 times a day, it could be discontinued much sooner. What about routine AM labs? Every hospital patient has to have those, right? But do you really need them? And do you need all of the labs that we always do? The daily chest X-ray, that's often commonplace done in intensive care. And I think we've read about screening colonoscopy for more elderly patients. What's the risk versus the benefit there? Apparently, and I'm a pediatrician, so I have no qualifications to speak about this, but apparently you can treat uncomplicated DVT as an outpatient, and that can be done safely. In the hospital, sometimes we'll put telemetry on patients. We may put it on too many patients and leave them on too long. And there are certain tests that could easily be done as an outpatient that don't need to be part of an inpatient stay, and the same for some consultations that might be better done after the patient leaves, after their acute condition is resolved. So these are all things that they came up with sort of on the hospital side that they've asked us to think about as opportunities to reduce utilization while patients are in the hospital. And sort of the next frontier on all of this gets away from the hardcore, exactly what's happening in the hospital and the hardcore aspects of quality, and onto patient satisfaction, which it's good to see that most of you think that this is important. This is becoming extremely important for hospitals, and in fact, the CMS Pay for Performance program for hospitals now, 30% of the score is based on our scores for patient satisfaction. And then the next one, readmissions, very controversial, but CMS is now holding hospitals accountable for readmissions that occur within 30 days of when they leave the hospital. And if you think about that, we all want to reduce readmissions, and certainly the hospital, if someone comes back within the first few days, no argument there, but the 29th or 30th day, that's really going to be impossible for hospitals to do without close cooperation with physicians outside the hospital. It's going to have to be all of us working together, such as your MyPIC program and some of the other things that are coming down the pike, but there's no way that either one of us can win that battle alone. And this is a penalty that starts at 1% and it ramps up to as much as 3%, that's a lot when it comes to Medicare because of how dominant a payer that is. And of course, the commercial payers are going to follow on this. This is just an example of what the patient satisfaction data looks like online if you go to that Hospital Compare website. And there is a question on there about physicians, patients who reported that their doctors always communicated well. And you can see at Beaumont we're a few points below the state and national average on that. So we've got work to do.